Hi, my name is Jennifer Cooper, and today I'll be presenting a case study on Pityriasis rosea in an adolescent patient. Pityriasis rosea is an acute self-limiting papulosquamous skin condition most commonly seen in adolescents and young adults. It typically begins with a herald patch followed by a generalized rash on the trunk and proximal extremities. PR is thought to have a viral etiology most commonly linked to human herpes virus 6 and 7. This is supported by the fact that many patients report a preceding viral-like illness, such as headache, malaise, or sore throat. Although the exact mechanism is not fully understood, current evidence suggests a T-cell mediated immune response with involvement of viral antigens in the skin. It most commonly affects adolescents and young adults. It is not considered contagious and typically follows a self-limited course. Patients may have a mild prodrome such as headache or sore throat. The rash begins with the eruption of a single round or oval inflammatory lesion termed a herald patch that morphs into an annular scaly lesion. It is followed by the eruption of smaller maculopapular lesions with or without scale that spread along skin cleavage lines, forming a Christmas tree pattern. It may be pruritic, but is often otherwise asymptomatic and typically resolves within 4 to 6 weeks with supportive care. Now on to the details of this interesting case. This case involved a 15-year-old African-American male presenting with a spreading rash. The rash began on the face and spread to the trunk, chest, neck, and proximal upper and lower extremities. It was preceded by a sore throat. The patient reported itching, but no fever or systemic symptoms, and denied any new medications, sick contacts, recent illness, or other exposures. The patient reported frequent sweating, heat, and sun exposure from participation in football and track. On exam, the patient had multiple oval, salmon-colored plaques with fine scale, widespread maculopapular lesions, including a larger annular scaly lesion consistent with a herald patch. There were no vesicles or pustules and had no mucosal involvement. Diagnosis is clinical, and no labs were performed for this case, which is consistent with guidelines. Testing such as a KOH prep or syphilis screening can be used to rule out syphilis or tinea corporis if the diagnosis is unclear. Skin punch biopsy is rarely necessary, but if performed, it will show focal parakeratosis with or without ankathosis, spongiosis, perivascular infiltrate of lymphocytes and histiocytes, and occasional extravasation of red cells, which supports diagnosis. Key differentials considered included tinea corporis, secondary syphilis, guttate psoriasis, and tinea versicolor, which can present similarly to PR. However, these conditions were ruled out based on history, lesion distribution, absence of systemic symptoms, and clinical appearance overall. Here you can see the lesion characteristics of those differentials, which can be mistaken for PR or lead to inaccurate diagnosis. Management in this case was primarily supportive with a daily antihistamine to control pruritus and an emollient to moisturize the skin to encourage healing. A short course of oral glucocorticoid was also prescribed due to the heavy, widespread inflammatory distribution of lesions. PR is self-limiting and typically resolves within 4 to 8 weeks. This patient and mother were reassured. Education was provided on methods to protect skin, to avoid irritation, and prevent secondary skin infection. Mother and patient were advised to follow up if new symptoms emerge, worsen, or fail to resolve. Evidence-based guidelines emphasize that diagnosis is clinical and treatment is supportive. Routine labs are not recommended and most cases resolve without intervention. First-line management of mild pruritus can include a topical medium-potency corticosteroid, topical antipruritic lotions, or an oral antihistamine. Although it is not recommended due to clear or limited data for efficacy, treatment for severe presentations can include oral acyclovir, phototherapy, or a systemic glucocorticoid. The patient and families may experience anxiety due to the appearance of the rash and concerns about contagion and spread, making education and reassurance key in the management of PR. Management involves the nurse practitioner for the initial diagnosis, treatment, and management. Referral is typically only needed for severe or unclear presentations or unique patient populations. A dermatology referral is appropriate for severe, unresolving, or atypical cases. Patients who are immunocompromised should be referred to an ID specialist for management, and pregnant women should be managed by a specialist due to studies linking PR to a heightened risk for spontaneous abortion. And these are my references. Thank you for your time and attention during my presentation on this interesting case of Pityriasis rosea.